A very good evening to all of you, and I welcome everybody to AIOC 2021, the 79th virtual conference. And I would like to welcome Dr. Chandrima Paul. Good evening, Doctor. You are very welcome over here. And now I'd like to hand over the virtual platform to Dr. Paul, and she can invite the first speaker.
Thank you very much. Thank you, AIOS Chair Scientific Committee and Team Scientific Committee for having our IC here this evening. And we have some glaucoma stalwarts this evening with us to speak in this IC, which is a little out of the way IC. It's called 2020 Glaucoma Strides. So let's see how long a stride we can take starting with the year 2020. We haven't been taking much of a stride with the virus on, but hopefully once we get over with the virus, we would be taking long strides in glaucoma in this decade that follows. So with that, I would invite our first speaker this evening. That's none other than Dr. Rajul Parikh. Dr. Rajul Parikh is the director of the Sriji Eye Hospital, and he is also the director of the Palak's Eye Clinic. And he's a brilliant glaucomatologist with decades of glaucoma experience. And we are here to listen to him on next generation perimetry. Over to you, Dr. Rajul.
Thank you, Dr. Chandrima. So I'll be talking about, I'm visible?
Yes.
Yeah, so future in perimetry. We know that automated perimetry is gold standard, is mandatory for glaucoma diagnosis and follow-up. Basically, it's a synonymous with the autonomous perimetry with the visual field testing in current scenario. Now, if you look the white and white perimetry, there are some issues like OAT study. If you look, OAT study is one of the biggest ocular hypertension treatment study. They found that the test rate as variability was very high, very high. In fact, 86% of the patient on retesting, they could not confirm the abnormalities which was seen on the first time. So what are the questions we are looking at? Can we improve on white on white perimetry? Can we diagnose glaucoma earlier than white on white perimetry? And can we have easier way of doing perimetry? There are other questions also, but in the lack of time, I will cover only these three questions. So the first questions that improving the technology. So there are certain publication in previous few years ago we had that the 10 days 2 picked up the more scotoma even in the early glaucoma compared to 24 days 2. And this is one of the example. You see there is an inferior thinning and the 10 days 2 is showing the fused scotoma where 24 is normal. So, and the logic is that because 24 days 2 uses 6 degree separation where 10 days 2 uses only 2 degree. So they are more point analyzed. So based on that, we have a new software 24 days 2C where there are 10 extra points are added on the 24 program and it is 24 days 2C program. And I'll just give one example. So 24 didn't pick up any glaucoma damage where there's a superior arcuate scotoma picked up on 24 days 2, basically of the 10 days 2 involved, the points. The second we have is compass perimetry. There is a scanning laser ophthalmoscope combined with an automated perimeter that provides the confocal image of retina as well as the retinal threshold sensitivity. And the again, it's different than 24 days 2 Humphrey. They have 52 points plus 12 points additional on the macular area and uses a ZES technology. And this is one of the example of the threshold and how it's superimposed on the fundus photograph. And this is the printout route. I unfortunately do not have any personal experience, but this is how it's superimposed. This is how the threshold value is compared on the different zone. And this is a standard Humphrey perimeter value. So this is how the different it looks. This is a compass. It has a potential. The third is the HEP, Heidelberg Edge Perimetry. Basically, it's a flicker-defined form perimetry. Again, uses the magnocellular pathway. The 5 degree circular stimulus created by the phase reversal, basically it causes the edge illusion. And the data shows that it picks up the perimetry, the glaucoma damage earlier than white on white perimetry. So these are some of the example I have borrowed from others. Again, I don't have the machine. The 24 days 2, the FDT, and this is HEP. So it picks up much earlier than more than FDT also. Again, but based on same magnocellular pathway mechanism. One more example. So this is HEP, the flicker technology. Now the newer concept is that, and the questions I have is that, can we screen patient from home? Can we monitor patient visual function from home? Can we monitor everything, glaucoma, basically teleglaucoma? We don't have to see patients. And can we screen which are threshold faster than current available tests? And I just try to answer. So home-based perimetry basically is internet-based and the virtual perimetry. There are lots of soft internet-based perimetry available. I've just given one example. ViewScope is a suprathreshold test. I have done personally. Basically screening test, and it's very simple, and it gives whether you have a defect or not, but it's a suprathreshold. So for the screening, the virtual perimeter, and there are lots and lots of virtual perimeter available. I have personally used the Palm Scan Visual Field 2000 virtual perimeter. Is based on VR gear and the mobile phone. So, in the current generation where we are using mobile and the virtual gear so often, is very easy. That the Palm Scan is both threshold and the supra threshold test. Is a 3 decibel staircase algorithm it uses. I'll not go, but it gives the mean deviation, pattern deviation plots like Humphrey perimeter. And this is one of the example. You can see the patient had inferior arcuate and central here close to fixation, the same thing. One more example, inferior arcuate, which is correlating again on the palm scan. The homonymous hemianopia, the patient had the same, very similar. It respects the vertical meridian also. So it sort of, the agreement was good between the Humphrey and the palm scan. The other is Melbourne rapid field test. It is based on the iPad tablet format. Again, it has a both suprathreshold and threshold. There are publications which shows there is a good agreement with the Humphrey. Again, I have not used. This is the Humphrey and this is the suprathreshold used with the Melbourne rapid fire. Very similar, and they have a threshold program also. So the question is that, can we screen patient from home? Yes, we can, because we have internet-based perimetry, we have virtual perimeter. Can we monitor patient visual function stability from home? At this point in time, no. We do not have progression software. There are lots of research going on, but unfortunately at this point in time, no. The threshold test which is there on palm scan or MRF, they do not have progression software. So we require some more research. The same question, though the IOP and everything was not part of my talk, there are lots of research going on, like the sensor which we can implant along with the IOL with glaucoma devices. So there will be lots of new thing coming up in next decade where we can manage the patients from the home only. And can we have screening tests which are threshold tests and faster than current available? So these MRF and all that are much faster, but we need more research, more data to say that we can use from the home. To summarize, we have a newer technology like 24-2, which is picks up more field defect than even 24. So there is a research in white-on-white perimetry, which we can be useful in day-to-day practice. There are technology like Compass and HEB perimeter, though we need more data, may be useful. They pick up the glaucoma earlier than white-on-white perimetry and would be used in day-to-day practice. And virtual perimetry in next decade is going to really change the scenario from screening point of view and maybe from diagnosis and monitoring point of view. Thank you.
Thank you, Dr. Rajul, for that very power-packed talk. In fact, what we see in visual fields is we are there to take very long strides in the next decade as far as visual fields are concerned. A lot of visual fields on the pipeline, and we look forward to using them in our day-to-day practice. Thank you very much once again.
Thanks.
And we'll move on to the next talk. The next talk by is none other than Dr. Shirisha Senthil. She heads the glaucoma service of the L.V. Prasad Eye Institute, Hyderabad. Dr. Shirisha is a versatile surgeon and a very prolific speaker. Welcome, Dr. Shirisha, and thank you for being a part of our course. Over to you.
Yeah, thanks, Chandrima. So we will start off with OCT in early diagnosis and progression. Glaucoma, as we know, is a progressive disease with loss of retinal ganglion cells and their axons with resultant optic nerve head damage. And what we see in these patients is a progressive loss of visual field as we go by if they are untreated. So our aim is to pick the disease up early, make sure that we don't have so much of a damage by the time it is diagnosed. And once diagnosed, make sure that it is stable. So these are the two aims of the diagnosis of glaucoma and treatment. So how do we pick up change or damage or progression? We can do that by two types of evaluation. One is the structural assessment of the optic nerve head and the retinal nerve fiber layer, and the functional assessment by the threshold perimetry, as well as the other newer perimeters that we are talking about. So structural assessment can be done by clinical evaluation of the optic disc stereo photographs, but we know that it is subjective, and majority of the time, if people are trained well, they would be able to pick it up, but sometimes it's not possible, or untrained people may not be able to pick it up. So, and it is not quantitative. So structural assessment with OCT is very, very important. So if we look at the relationship between the structure and function in glaucoma, we know that they don't go hand in hand all the time. Structural changes precede functional changes in the early disease and vice versa later during the disease. And there are multiple reasons for this. Once we detect the disease, what is important is the disease progressing? If we find a change in whatever way we are testing it, whether it is OCT or by visual fields, is it because of the disease progression, or is it because of the measurement variability, or is it because of a natural age-related change? I think this is very, very important for us to know before we call somebody as having a progression, because our diagnosis of progression is going to affect them by either changing the way we treat them, or sometimes even additional surgery may be required. So one needs to be very, very clear about it. OCT is important, like I said. This is a patient with preperimetric glaucoma. You can see an obvious inferior NFL defect. Visual fields are normal. OCT is able to pick it up both in the thickness map as well as deviation map and inferior NFL defect. So which structures are measured? We can measure the retinal nerve fiber layer thickness as well as the optic nerve head changes. And that is shown here as the neuroretinal rim thickness in the graph, as well as the RNFL thickness map, which is measured around the measurement circle. And it also gives the averages of the superior nasal, inferior, and temporal, as well as the clock cover maps. Macular GCC is also used to measure the macular ganglion cell complex, because we know that macular area houses more than 50% of the ganglion cells. So any change, even in early glaucoma, one would be able to pick that up. And the new change that we are able to pick up these days with the help of an OCTA is the blood supply and the blood flow that happens around the optic disc. And this is also shown to be affected, and this can be picked up, but currently we are not using this for detecting progression. You can ask me which one of these is better. Is the RNFL measurement better, optic disc evaluation better, or the GCC better? It is difficult to say, but I'll just share a few examples. This is a patient with an glaucoma, inferior NFL defect, and near notching. Visual fields are essentially normal. OCT is able to pick it up both by RNFL as well as macular ganglion cell complex layer. But what we need to remember is even by HVF, when we do a 10-2 for these patients, I think this will complement to what Rajul just said. 24-2-C is an advantage we have today, that instead of doing 2 tests, we should be able to do that to pick it up. But by doing a 10-2, a huge defect was there. So it's no more a preperimetric disease, it is a perimetric disease. RNFL and GCC do not correlate always. So this is a question again that is asked. So which sometimes, this is an example where a GCC was able to pick up the inferior RNFL loss, inferior defect or damage, whereas the RNFL was not able to pick up the change. Whereas in the left eye of the same patient, the defect was picked up, or the disease was picked up both by RNFL as well as the GCC maps. So sometimes they do not match. This is what we need to remember. And which one of them is better? In early disease, RNFL thickness performed much better than the GCC. That is very important. In an advanced disease, RNFL is very, very difficult to pick up change, because we know what is called a floor effect. I will come to that in a little while. But like in a 10-2, how we use 10-2 for an advanced disease is very important to use a GCC analysis for an advanced disease. So that's important. And especially when you have a disease with MD more than -17, which is a very severe disease, one will be able to pick up nothing on the RNFL analysis. In fact, it's as much as even 10 decibel loss, you will not be able to pick up changes. So RNFL helps, change helps to detect early disease. GCC helps in detecting advanced disease. These are the progression algorithms that we use. And what it does is it picks up the change that was not present at the baseline by serially focusing on changes that happen as we go by. So that's important. And they are highlighted in different colors, the way we know how these color codings work. But it's important to pick up a change. We also have a trend analysis that tells you what happens over a period of time. And a negative slope is a change, but all negative slope need not be progression. What level of change is very significant? A decrease of more than 5 microns in average RNFL thickness is suspicious of a progression for glaucoma. A decrease of more than 7 to 8 microns in a sectoral RNFL thickness suggests progression, and a decrease of more than 4 microns in GCIPL thickness suggests likely progression. These are just guidelines, but they are not hard and fast, but that is something that can help us. Sometimes we may be able to pick up missed changes, so that's also important. This is an example for the same. So also look at the thickness maps before one says that there is no glaucoma or there is no progression. Macular thickness, again, you can go by the macular GCC with a progression analysis as well. Always apply the results in the context of the patient. That's very, very important. Like I said, any negative slope is considered significant, but we need to remember that that may not be clinically significant. So we also have to understand the limitations of any kind of testing device that we use or any kind of technology that we use. Errors due to registration, errors due to coexisting retinal pathologies, errors related to the operator, segmentation errors, and age-related changes. This is one thing that is very important, age-related decline. We know that normal decline also there is a change, and an age-related decline is very important, and the OCT currently does not take that into consideration before calling somebody is progressing or not. So we may be overestimating a disease if we are not careful. Floor effect is something where if the thickness of RNFL falls below 550 microns, even if the disease is like, let's say, no PLI, we will still be not seeing any decrease in the RNFL thickness. So that is called as floor effect. That is because of the non-neural tissue that it measures. So in an advanced glaucoma, it is not useful to measure RNFL thickness and go by the GCC. Any decentration of the circle again can cause changes. Retinal pathologies can cause problems. So these are things that one needs to be cognizant about. And to summarize, glaucoma progression by OCT or picking up the disease early by OCT is very, very important, but one needs to take this in context with the patient, looking at how the disease IOP as well as the visual fields before one takes a decision, and not just go by what is shown by OCT. Thank you.
Dr. Shirisha, for that great talk, informative and relevant, and absolutely the salient features, so to say, broadcasted. Thank you very much. And with this, we'll move on to the next talk. The next talk is on medical management by Dr. Devan Tuli. Dr. Devan Tuli is a glaucoma consultant at New Delhi. He is a versatile surgeon, eloquent speaker, and great organizer. So over to you, Dr. Tuli, for your talk.
Yeah, thank you, ma'am. So just wanted to say that the algorithm that is current, I have divided into two parts, because for the most part, the right side, this one, most of the masses in India, the general doctors are using this still, timolol. If needed further, they would go to brimonidine, timolol, or one of the combinations mentioned in the second line. And if further required, they would add. So still prostaglandin does not figure much in the two bottles that they use. What we do in the 2020 glaucoma, the 2021 glaucoma scenario today is on the left side of the column. So we tend to start treatment with prostaglandins. I think the compelling reason is not just the efficacy, which is the highest with prostaglandins, but for me, the second point is quite important, that they provide good day and nighttime control of IOP. So I think if that is a pushing reason, that is the one to start using prostaglandins first line. If further required, then we use a combination of prostaglandin timolol, and then we would add another drug if that is a patient needs further reduction, which could be any of these, brimonidine, dorzolamide, pilocarpine. And as the next step, we use two bottles, which typically would have 4 drugs, prostaglandin timolol in one and brimonidine, brinzolamide in the second. I think this has been there. This combination has been there in India for about three odd years. But what I can say for the theme of the course today, that in 2021 or 2020, it's become more established. So many more companies are producing this, availability is there, and the cost has come down. So let us look at this part of the slide here. For me, this is important to know that 2 bottles, which typically would contain 3 to 4 drugs, is maximum tolerated therapy with the medical management scenario concerned. Anything more than this, a lot of the patients are not able to tolerate. That is, if you give a 3rd bottle. So with this in mind, the left and the right column for a glaucoma person and a general ophthalmologist, let's see what is new now. So we have Tefloprost, which has come in to add to the Latanoprost, Trabicolectomy, and Perimetry that we've had. The efficacy is quite similar to 30 to 35% IOP reduction. But I think the good thing about Tefloprost is the unions. So that is the new thing or the good thing in today's scenario. Then we have other new stuff like the ROCK inhibitors. The good thing is they have 2 mechanisms of action with 2 possible targets. And one of them is metazidil. And the 2 mechanisms mentioned here, they give us, a different perspective, some teeth to our glaucoma treatment. So that is good with a complementary mechanism. They can be added on to the drugs that we saw in the first slide. We also have ripasidil. We have limited. So the question now is that can these replace as the first line what I showed you on the first slide, whether it was timolol, whether it was prostaglandin. I think all my panelist colleagues today will agree that we have limited experience. I think the lockdown has not helped with the experience building. So once we use more, but what we know already is that patients complain of hyperemia, some reports of conjunctival hemorrhage. There is blurred vision reported with cornea verticillata 2, which is also known as vortex keratopathy if you use it for some time. But I think these are the negative things. But the good thing is that it can work. It's said that endothelial part is good with this. So that is something we have to look at. But yeah, this is a new thing which we can add to our list. I'll come to that where we can. So whether it's 2020 or 2021, please remember that still the basics of medical management is to set target pressures. So just to reinforce the audience, for ocular hypertension and early glaucoma, we aim for reducing the pressure by 20% for starters. For normal tension glaucoma, you reduce it by 30% straight away. Moderate to advanced glaucoma, 30 to 40%. And keeping this in mind, which drug to start first when you're treating early glaucoma or ocular hypertension? I think which drug to start first, you can use any of these mentioned here, because all these should give you about 20 to 25% IOP reduction. And remember in the previous slide, this is the IOP reduction that you need for early glaucoma. So you can use this, any of these, and then you can, see the side effects and then change according to the patient profile. When you're starting with prostaglandins, I think I've already said this, these give about 30 to 35% IOP reduction. Some colleagues actually don't like to use this, and I showed you in the first slide, they actually use a brimonidine timolol combination a lot, especially in the area I practice in. A lot of general ophthalmology colleagues in India actually are using brimonidine timolol, dorzolamide timolol as first line. Now that is not bad because that should also give you similar IOP reduction of 30%. But remember the golden rule of medical management of glaucoma is mentioned in the last line of the slide. As far as possible, use monotherapy or less drugs. So there are drugs like prostaglandins which can be used as single drugs and will give you 30% reduction. And I remember what I said in the first slide. I think that nighttime control of IOP is a very compelling reason to do that. Now, also the nighttime control, I think we had a GSI webinar where we stressed so much on nocturnal IOP. Remember, in addition to prostaglandins, there is one more drug that we have with us today in 2020 glaucoma, which can reduce the IOP reduction at night especially, and that is actually dorzolamide or brinzolamide. So this is a good choice to use, dorzolamide, where you need further reduction of nighttime IOP. and also they enhance the ocular blood flow. Brimonidine you can add to prostaglandin as your second adjunct drug or second line drug. Remember, if timolol is you cannot use, then you are supposed to use 2 separate bottles. So brimonidine is good because it has been shown to be neuroprotective with some authors at least. So it's a good drug to use in normal tension glaucoma and advanced glaucoma. Now, I push a lot for combination therapy. And the reason is actually the compliance improves is okay. But for me, the second reason is more important. Preservative load. So this is the reason that we use a lot of combinations, and I would add prostaglandin to timolol, which I showed you in the first slide also. And then we have this combination, which I mentioned too. So when timolol you can't use, then I've said you can use nilotinib accordingly. And the last slide, I would say that when further IOP lowering is required, I've already said this, 3 to 4 drugs contained in 2 bottles, I've called it maximum tolerable therapy. When one of these drugs you can't use, suppose you can't use timolol or you can't use brimonidine because of allergy or blepharitis, then I think these drugs, which ROCK inhibitors that we talked about, they are giving us that option of either, using ROCK inhibitors in place of one of the drugs which may be intolerant, or very rarely in my practice, I don't use third bottle. It can serve as a third bottle and can give us further 4 to 5 millimeters of IOP reduction further. So before jumping to laser trabeculoplasty for open angle glaucoma or to TRAB, you can use these. And I think in the last 2 odd years only we've had this, and more experience will. Now, when you add a short course of acetazolamide and glycerol, then the term is maximum therapy. So keep that in mind, maximum tolerable and maximum medical therapy. I'll just stop here. Thank you, ma'am, for the opportunity. Always a great course of yours.
Thank you. Thank you very much, Dr. Devan. That was indeed a very straightforward guideline to medical management. And medical management is something of glaucoma, which I think every ophthalmologist basically does in his or her clinical practice. So those guidelines would be very helpful for all of us who actually treat glaucoma patients. Thank you very much. So now we'll move on to Dr. Sunita Dubey. Dr. Sunita Dubey is the medical superintendent of the Shroff Charity Eye Hospital. She's a well-known glaucoma surgeon, and she has been categorically at the pinnacle of the MIGS, which is trying to revolutionize glaucoma surgery. And that's another field where I think we are going to take very long strides in this decade in MIGS. So over to you, Dr. Sunita, evolution of MIGS.
Thank you, Dr. Chandrima, for giving me this opportunity. Okay, so we know that filtering surgeries have evolved into highly effective procedures with the introduction of MMC, with IOP reductions as high as 50% in most of the patients. However, they may be associated with sight-threatening complications, and we are very well aware of them. So the advent of MIGS with better safety profile has definitely created a way to bridge the gap between medical management and filtration surgery. If you look at this management spectrum, MIGS are exploited after the options of medication and laser is over. However, they can be used even earlier in the course of the disease with cataract surgery, and also in patients who are allergic to the drops or where the cost and non-compliance is an issue. So MIGS can be classified based on the physiological mechanisms and anatomical site of action, and they are used to overcome the resistance at the Schlemm's canal or the trabecular meshwork, or improve the flow at the suprachoroidal space, subconjunctival space, or ciliary body. So we have been using some of the MIGS in our practice, and we have started doing some of them like GAT and trabectome and the hook dual blade. And now the new addition is iStent. It is going to be launched soon. They've got the approval, and there's a lot of scope to use and potential to use preserve flow, especially in the advanced glaucoma because of very well pressure control. So coming to trabectome, an anatomical consideration, if you look at the anatomy, the site of maximum resistance is trabecular meshwork and canal, which drains into 25-35 collector channels to drain aqueous into the intrascleral and then the episcleral vein pressure, and the concentration is maximum on the nasal side. Trabectome is a plasma-mediated ablation system, and the biggest advantage is that it has a constant infusion and aspiration system, which maintains the chamber very well and provide the visibility to facilitate ablation. And this is very, very important. When you are going to treat the trabecular meshwork, you have to have a very good visibility. Also, it has a foot plate, which helps guide the electrosurgical tip and protects the adjacent tissues. Again, the advantage with trabectome is that it's an excisional goniectomy. So it achieves complete removal of the diseased trabecular meshwork, as you can see here, and it also prevents scarring and reocclusion of the collector channels as compared to the incisional goniectomy, wherein there are chances of apposition of the edges again. Trabex and Trabex Plus are the laser cut serrated blades, and which are compatible with phaco, so they do not have an inbuilt irrigation and aspiration, but you can connect them with any phaco machine to do the procedure. So I'm just showing this video. So before starting the case, it's important to adjust the head of the patient and the microscope so as to have the angle of 70 degrees. And also it is important to visualize the trabecular meshwork which you are going to treat with the help of this Swan-Jacob type of gonioscope. And the incision is temporal, 1.6 to 1.8 millimeter. And this is the probe, irrigation on. You have to enter across the anterior chamber to engage the trabecular meshwork. And once you engage the trabecular meshwork, you can start ablating on one side. And as you start ablating, you can see this white line, which is suggestive of the outer wall of Schlemm's canal. That means you ablated the inner wall of Schlemm's canal and the middle third of trabecular meshwork. So you can, in one setting, you can ablate up to 140 degrees of trabecular meshwork, and then you can go ahead with your phaco in your usual manner. And in cases where the trabecular meshwork is not so pigmented, when you decompress the eye, when the pressure is low, you can see this blood in Schlemm's canal. So this is the identification, how you identify the trabecular meshwork. And after ablation of trabecular meshwork, you have ooze of blood, and sometimes it is little much. So advantage with phacotrabectomy is that by the time you finish this phaco, that ooze will stop, and otherwise you have to do irrigation and aspiration to take out the blood. So after surgery, you can see this clear cleft. This was a patient with pigmentary glaucoma. You see a lot of pigments here, but here you can see the pigments have disappeared, and you can see this cleft. So that means your surgery has worked, and studies have shown good efficacy in terms of IOP control and reduction of medication. A hook dual blade is designed for improved excision of trabecular meshwork, and it's a single-use disposable blade with sharp tip, which is used to pierce the trabecular meshwork, and it's a dual blade which create paired incision in the trabecular meshwork. And as you can see here, also you will create this cleft into the trabecular meshwork, suggestive of your procedure being done at the right place. GAT is getting popular in India again, especially the suture GAT, because it is quite cost effective, and it has been described by Dr. Grover et al. And here microsurgical forceps are used to advance either microcatheter, but that is expensive. So in India, we have been doing suture GAT, and it shares the trabecular meshwork to create a 360-degree trabeculotomy. So advantage with this is that you are creating 360-degree trabeculotomy. Eye stent, as I said, is the latest addition, and it's going to be launched soon. And again, It improves aqueous outflow through natural physiological pathway, and it has an excellent overall safety profile, similar to similar or better than when you're doing cataract surgery alone. And 7 lakh eye stents have been implanted so far across the world, and a lot of literature is available. So now the latest addition in this is Inject, which is technologically more advanced and easy to use. So it has 3 parts: the head, which resides in the Schlemm's canal, thorax resides in trabecular meshwork, and flange. So this is the new one, and this is the injector through which you inject. And just to show you this video, and this is similar to the trabectome procedure. Here you are just injecting with the help of injector this eye stent. So you just have to release it from the injector, and it fits into the trabecular meshwork. The procedure as such, I think the procedure is going to be easier than trabectome. And here, this is an animation video of eye stent inject, wherein you inject 2 eye stents. So after implantation of first, you move 2 clock arc away and implant the second stent. So you just have to release it. It's an easy procedure. Yeah, of course, intraoperative gonioscopy you should learn before performing these procedures. So definitely, we have now more options in our armamentarium. You can use them, and with the advantage that you are preserving conjunctiva for more invasive glaucoma surgeries for future. However, it needs more evidence to decide the best treatment option. Thank you very much.
Thank you, Dr. Sunita, for that very, very interesting talk. And this is actually something which we're really looking forward to in the coming decade. And we shall come to the discussion when we need more inputs from you once we finish off with the talks. The next speaker is none other than Dr. George Puthuran. He is the head of glaucoma services at the Aravind Eye Hospital, Madurai. And Dr. George is the inventor of the ADI, which we all use. And I gave him this topic, glaucoma filtration devices without hypotony, a realistic aim, because the second ADI I did met with such severe hypotony. So let's hear it from the horse's mouth. Over to you, Dr. George.
Thank you. Thank you very much, Dr. Chandrima ma'am. So the rates of low intraocular pressure after trabeculectomy has been reported to be about 1.6% to 12.4% in clinical trials, and it can be, it was also been reported from about 7.2% to as high as 42.2% in observational studies. So this is a discussion I found in one of the TVT papers by the TVT group in the tube versus trabeculectomy study group, where they say a limbus-based conjunctival flap was used in most patients randomized to the trabeculectomy group, and mitomycin C was used of a concentration of 0.4 milligram per ml was applied intraoperatively for 4 minutes. A trend towards use of phonics-based conjunctival flaps with a more diffuse application of MMC at a lower dosage has developed since the TVT study was initiated. This modification in surgical technique may result in lower rates of hypotony and Rep-related complications after trabeculectomy. And inevitably, both these references, the 12 and 13, are to Sir Peng Kor and to the Moorfield Safer Surgery System for trabeculectomy. So the more I looked into the literature on this topic of glaucoma filtration surgery without hypotony, the more I realized it was again back to the very basics. A lot of literature was focused on the use of antifibrotic agents, especially mitomycin C, concentrating on area of application, the concentration of mitomycin, and the duration of exposure. Younger age and myopia were 2 predisposing factors I found in a lot of literature, and then the surgical technique and post-op bleb maneuvers. So this is what the TVT paper was talking about. Initially, we used to have this limbal-based conjunctival flap where there is a posterior restricting scar, the ring of steel. There is a tendency for the aqueous to percolate anteriorly. The mitomycin application would have also been occurred anteriorly, and this resulted in thin-walled avascular, very cystic blebs, which would predispose to ocular hypotony, not only ocular hypotony, but also to blebitis and bleb-related endophthalmitis. The Moorfield Safer Surgical System, they said it would be best to use polyvinyl alcohol sponges for mitomycin application. We still continue to use these Vexel sponges, methyl cellulose sponges, and these can be cut freehand into longitudinal strips, after which you apply the antimetabolite onto these longitudinal strips. They become flat rectangular strips that can be easily insinuated and taken out from the subconjunctival space. So we try to treat as large an area as possible. It's about 6 to 8 millimeters of conjunctiva and tenons is dissected flush with the limbus, but you do a posterior dissection so that you have about 10 to 12 millimeters of space for the antimetabolite treatment, and you try to treat as large an area as possible. It's essential to make sure that the mitomycin doesn't touch the cut edges. So you need to handle the conjunctiva very carefully to avoid buttonholing. It is also prudent to have a count of the number of sponges that have gone in and that are coming out. So again, there's a lot of literature, but unfortunately, there's no consensus on the concentration, on the exact concentration and the duration of and the exposure time for mitomycin C. But I went through a lot of literature, and the general consensus seems to be about 0.2 milligram per ml for 2 to 3 minutes. This is something which we found very useful. This is in the textbook of Yanov's textbook of ophthalmology, in which there's a chapter on antifibrotic agents, and this is about more flow regime. It's from Moorfields Eye Hospital as well as the University of Florida, where they have beautifully segregated patients according to the risk of failure into low risk, intermediate risk, and high risk, and also they have delineated the how much of antimetabolites, what concentration of antimetabolites, and what the duration to be used. Ultimately, it's all about periodically revisiting your results, titrate according to the response you find in your patients. For example, probably about 4 to 5 years back, we were using 0.2 milligram per ml for 2 minutes for our intermediate risk. Like for example, a glaucoma triple, we were using 0.2 milligram per ml. And we felt that we needed to switch on to 0.4 milligram per ml for 2 minutes because we were seeing a lot of bleb scarring, probably due to a lot of medication use preoperatively. Again, there is a lot of literature on injection mitomycin, and I think this is something which we need to visit. This publication is about intratenon injection of mitomycin. They used 0.1 ml of a range between 0.05 to 0.4 milligram per ml. This is another publication of ophthalmology glaucoma where they used subtenons injection of 0.1 ml of 0.1 milligram per ml. All these publications definitely say that this is as safe and as efficacious as use of mitomycin sponges. We have also started using injection mitomycin. We do it subconjunctivally, and we use a concentration of 0.04 milligram per ml subconjunctivally. And once the mitomycin is injected subconjunctivally just before surgery, we take adequate precautions to make sure that it is as much of it is spread out uniformly at the site of the scleral incision. Ologen is something, there's not much of time to go into the details, but this is something, it's a biodegradable implantable scaffolding matrix. And unlike mitomycin and other antimetabolites which promote extensive cell death and avascularity, proponents of Ologen use say that the fibroblasts are taught to grow in an orderly manner. And it's all about regenerative wound healing. And in our hands, younger age group, especially the primary juvenile glaucoma, myopia, any presence of scleral thinning due to any reason, like a previous history of scleritis, are indications for Ologen use over a mitomycin use. Again, coming to the surgical part, failing filter can occur due to hypotony in the immediate postoperative period due to a low bleb, due to bleb leak, and also can occur due to an elevated exuberant bleb where there's obvious overfiltration and hypotony. So once we shifted over to these fornix-based blebs, fornix-based conjunctival flaps from your limbus, well, you close the conjunctiva at the limbus, we found these to be a persistent problem. The bleb leaks are much more common with limbal-based, with fornix-based congenital flap, unlike the limbal-based flaps. And so this is something which we found useful, anchoring the conjunctiva at the limbus with a 10-0 nylon suture, so that the whole of the conjunctiva is firmly anchored. Apart from your vicral sutures on either side, the whole of the conjunctiva is anchored firmly at the limbus. And to a great extent, this is taken out from the equation, the problem of blood leak with fornix-based conjunctival flap. And coming to the last part, hypotony due to overfiltration immediate postoperative period is a serious problem for the glaucoma surgeon. It can occur due to inadequate scleral flap sutures. If there's enough structural integrity, you can apply more sutures to tamponade flow. But I hear in this patient, there is a flap hole, there is a cheese wiring, and these end up with, you have to place some kind of donor material. So it again comes back to the basics. It's very important to have adequate scleral flap thickness and adequate scleral flap size, so that there is adequate coverage of your ostium. And also, it's important that there is enough tissue on either side of your ostium, which is very, very important. So this is what I was mentioning. You need to have adequate tissue on either side of your ostium, whatever. And again, the flap has to be reapproximated. The bottom line is your anterior chamber should form well at the end of the surgery with injection of saline. Again, extremely important to be aware of complications of aggressive ocular compression, suture lysis, and suture release. And it's important to keep in mind that many of the sight-threatening complications of glaucoma filtration surgery are associated with hypotony rather than increased pressures after glaucoma. And special attention to the area of MMC treatment, your conjunctival and scleral flap construction, and fixed and releasable sutures will to a great extent take out this disaster.
With due respect, may I request the doctor to please sum it up? Thank you so much, sir.
Yeah, thank you. So thank you very much, Chandrima ma'am. That's all.
Carry on. You can just finish your talk, Dr. George.
Yeah. I know. I just wanted to say that it's important that you adopt techniques that work well in your hands and make sure that you perfect it to produce repeatable outcomes possible. Thank you very much.
Wonderful. That was a brilliant talk, and your videos were a treat for us. Absolutely wonderful. Thank you very much. We shall come back to you in the discussion. In the meantime, since Dr. Shushmita, is she here? Shushmita, you're here. Yes. So Shushmita, you can start your talk. Dr. Shushmita is a professor at the Advanced Eye Institute, Chandigarh, and she is not only a versatile surgeon, a prolific speaker, and a great teacher. So over to you, Shushmita, for learning gonioscopy versus UBM.
Thank you so much at the outset, Dr. Chandrima, GSI and AIOS for having me on. I'll be talking on gonioscopy versus ultrasound biomicroscopy with no financial disclosures. There's no debate actually, because I think it's quite obvious. The outline in the next couple of minutes, we'll look at vital insights for diagnosis versus questionable information, feasibility and ease versus equipment, what is the evidence, and what do all the experts say. So gonioscopy is the gold standard against which all anterior segment devices are evaluated, whether it is a UBM, whether it is the AIOC, they're all asking the question of whether or not it is as good as a gonioscope for evaluating the angle. There's no question about the ease, cost, and feasibility of gonioscopy, where one of my favorite pictures of doing it in a 3-year-old girl versus the bulky and the big instruments that we need to have. If at all there's a debate, it would be probably in primary angle closure disease, because Asians will represent 87% of those with ACG by 2020. And this is an old study. So now I'm not sure how much they do represent. And 91% of people bilaterally blind are with PACG. So when we acquired the UBM, we looked at, and we were sure that the objective method would be better. But when we evaluated the anterior chamber angle in Indian eyes by UBM and gonioscopy, we were quite astonished to know that gonioscopy actually scored almost as well. So we learned that we don't need imaging to tell us if the angle is open or closed. What about in plateau iris? Yes, of course, the UBM brings it up beautifully. You can see this knuckle of ciliary body pushing up the iris to close the angle. But then a double hump sign observed on indentation gonioscopy was strongly correlated with the presence of a plateau iris or UBM. So plateau iris configuration, if you look for it, if you're wondering why your pressures have not come down after an LPI, for instance, and if you just do an indentation post LPI, you would see this knuckle of ciliary body which is pushing up the iris against the angle. So gonioscopy can do that as well. But then a gonioscope is indispensable if iridocorneal trabecular contact is present, whether you want to know whether it's appositional or synechial. So this appositional closure would look like this on the ASOCT, but the ASOCT is not going to tell you whether or not this will open up on indentation, whereas your gonioscopy, you just need to press it. You can see these Descemet's folds, the cornea, and you can see the trabecular meshwork, which is visible. What about its utility in trauma or say pigment dispersion? So this is a cyclodialysis cleft, which I can see with gonioscopy, but I can also image with UBM if I want. Plateau iris is shown up nicely on the UBM, of course, but then you can see concave iris configurations, and post LI, this is what happened to the iris and this is what happened on the UBM. Whereas angle recession and cyclodialysis is demonstrated well, but then you could do all of this with a gonioscope as well. So do I need the UBM to tell me all that? And how would imaging show a subtle Stampa-Ulysses line in pseudoexfoliation or a painted trabecular meshwork as we see in pigment dispersion syndrome, or a blood in Schlemm's canal in Sturge-Weber, or broad-based peripheral anterior synechiae in uveitis, to be differentiated with the characteristic iris processes in an Axenfeld-Rieger. So there's no question that for qualitative angle assessment, you need the gonioscope and you can't have it on the UBM. To carry on, how can imaging show you Coben wreaths? These are iris nodules or peripheral anterior synechiae in Chandler's, or a neovascular glaucoma, or even emulsified silicone oil in the angle after PPV. But now let's see the evidence. So big question, is it useful for screening? And I just pulled out these papers comparing the gonioscopy and screening tools for angle closure. So here you have 2,000 plus subjects screened for narrow angles using a peripheral anterior chamber device, an IOL master, and ASOCT. And gonioscopy was the reference standard. So the sensitivity and specificity of all these equipment were less compared to a gonioscope, and the low specificity may limit the usefulness of these devices in screening for narrow angles because you're going to miss them. Again, to detect PACS, 425 eyes were taken, diagnosed by gonioscopy. They used the Van Herrick, the ASOCT, and the Pentagap. Now, the ASOCT had the specificity of just 87% and the Van Herrick of 92%, but none of these tests evaluated achieved a combination required for a population-based screener. Is it observer independent? A scleral spur could not be detected in approximately 30% of anterior chamber angle in any of the quadrants. Now, if you don't detect a scleral spur reliably, none of these equipment is going to tell you anything about your anterior chamber. So this is a nice comparison of a Visante ASOCT, which easily gave a lot more penetration and a lot more angle assessment, Cirrus ASOCT and gonioscopy. So angle closure was detected in 18%, 16%, and 48% of quadrants using the three respectively. The scleral spur was identified only in 56 and 50%. Now these are by people who are looking for the scleral spur. So I'm not even looking at a garden variety everyday glaucoma clinic. And a slight agreement with gonioscopy, very slight with Visante and Cirrus, but a good agreement in angle closure assessment across examiners. So clinical examination with gonioscopy, even then, is better than the others. And then what do the experts say? This is the WGA consensus statement. I'm sure all of us have read that. Gonioscopy is indispensable to the diagnosis and management of all forms of glaucoma, not just PACG, and is an integral part of the eye exam. And I love this part. Anterior segment imaging may augment the evaluation, but their place in clinical practice needs to be determined. Now, don't get me wrong. Imaging is indispensable in certain situations where gonioscopy doesn't have the answer, but it's not a replacement, it's complementary. And we've seen this in many, many eyes. I mean, UBM in childhood glaucoma has changed the situation for us. We've made wonderful diagnosis based on the UBM. We've published on all sorts of things on why the UBM is essential, but it's not essential for looking at the angle. So to conclude, gonioscopy remains indispensable. Imaging devices are not without their limitations. Anterior segment imaging may be revolutionizing angle closure assessment, but clinical dynamic indentation gonioscopy is the way to go, and they augment clinical practice and are useful tools. But there's no versus with gonioscopy. Thank you. Thanks a lot.
Thank you very much, Dr. Shushmita. That was indeed a very, very relevant, salient take-home message given about gonioscopy and the UBM. So we'll come to you because there are questions regarding that. So I'll just share my screen and finish off my talk quickly. So I'll just to complete the course, I'll just take you through lasers and ultrasound for refractory glaucomas. And refractory glaucomas comprise all forms of glaucoma in which the IOP remains uncontrolled despite maximum tolerated medical therapy and previous laser or surgical procedures. IOP remains uncontrolled also after repeated standard filtration surgeries, and surgical approaches for refractory glaucoma include techniques increasing the aqueous humor outflow, that's filtration procedures or drainage devices, and techniques reducing the aqueous humor inflow by destroying portions of the ciliary body. Now, several cycloablative methods have been proposed over the years, like cryotherapy, microwave heating, endoscopic laser photocoagulation, transscleral diode laser photocoagulation. And given the occurrence of potential vision-threatening complications, unpredictable dose-effect relationships, significant variability in the final IOP lowering, and poor reproducibility, the ciliary body ablation is still considered as a last resort treatment, recommended only in patients with refractory glaucoma. So the high intensity focused ultrasound technology was proposed as a safe alternative of ciliary body destruction in the 80s and 90s by Sonocare. This technique permits a selective thermic effect on the target organ, limits damage to neighboring tissues, and allows treating non-optically transparent structures. Nevertheless, because of the excessive complexity and duration of the treatment, the technique was progressively abandoned despite evidence of good efficacy and safety. In the last 3 to 4 years, this has again been reconsidered after critical clinical modifications and significant improvements in all steps of the procedure. So talking a little bit about cytophotocoagulation, we have the transscleral cytophotocoagulation and we have the endocytophotocoagulation. So cytophotocoagulation actually reduces aqueous production by destruction of the ciliary epithelium, and the techniques are transscleral, transpupillary, and endolaser. Indications I just told you, failure of multiple filtering surgeries and the rest of it. So diode laser transscleral cyclophotocoagulation, method of ciliary ablation with success rates from 40 to 80 and performed with the diode laser. And these are specific with the endoscopic laser cytophotocoagulation performed also with the diode laser, and the actual time of exposure is based on visual effect of ciliary process shrinking and whitening. And we have the cyclodestructive procedure, the continuous wave cytophotocoagulation, that's the ab externo and ab interno, and the micropulse cytophotocoagulation. So what we're actually going to talk about is the micropulse, which is being used nowadays. So endocytophotocoagulation, this is for mild to moderate glaucoma done with cataract surgery, relatively low risk, and of course is to be avoided in uveitic eyes. So endoscopic photocoagulation is a cyclodestructive procedure, and it functions to minimize the disadvantages of more traditional cyclodestructive procedures and delivers laser energy to the ciliary body, ablating the ciliary body epithelium to decrease aqueous formation and thereby lower the intraocular pressure. So this is what is being used nowadays, micropulse cytophotocoagulation. It's a gentler form of the cytophotocoagulation, and it appears to work very much like the drop pilocarpine. It has a mechanical effect, and it's a low risk profile, and you actually apply it in a semicircle over the hemisphere, and there are time gaps after each application. So this study actually shows that it uses the slow application of laser energy that is chopped into micropulse or bursts and does not burn or destroy the eye tissue. And the results, as you see out there, 33% IOP reduction at 18 months and 61% reduction in medicines, glaucoma medicines, after doing this treatment. So at a glance, micropulse scleral cyclophotocoagulation has proven to be safe, effective, and reliable approach for lowering intraocular pressure. Unlike other interventions, delivers energy in a 31.3% duty cycle, allowing tissue to cool between each application. So there is a minimal impact on target tissue and a reduced risk of injury to the adjacent ocular tissue, and can be used early in disease course and requires minimal medication, reducing the reliance on anti-inflammatory drops post-op procedure. It can also be used on a wide range of glaucoma glaucoma cases, depending on the severity, and of course in most advanced cases of disease progression. Then we have the ultrasound cycloplasty. It's a novel device employing high energy focused ultrasound for the coagulation of the ciliary body, with the aim of achieving selective coagulation of the ciliary body while sparing the adjacent structures. The high intensity focused ultrasound is a non-invasive procedure that delivers highly concentrated sound waves to the ciliary body, reducing aqueous production and increasing the outflow, thereby lowering intraocular pressure. So UCP brings about a reduction in intraocular pressure via multiple mechanisms of action that result in decrease of aqueous humor production by selective destruction of the ciliary body, increase in aqueous humor evacuation by inducing a stimulation of the suprachoroidal and transscleral portions of the uvascleral outflow pathway. And these are videos of we did a small study with it, and that's the machine that you see out there. And this is the docking instrument, the cup with which you have to create vacuum. The green line that you see out here is when your instrument is ready to start firing the ultrasound waves. And once you do on one hemisphere, you got to turn it around, and you can do on the other hemisphere. And you can actually choose your time interval, and there's a gap of 20 seconds between each. So I've chosen, say, these two, and the ultrasound will be delivered to that particular area, and that's 20 seconds. And then again, there's a 20-second gap time after it goes and delivers ultrasound to the other area. So that is the time that it shows. And so that's the ultrasound being delivered, that you can see those red Wi-Fi-like lines. And then once the procedure is done, this turns red. And then again, there's a gap of 20 seconds, and it will go on to the next one. So that is how it is done. Results of therapeutic ultrasound that's our study over for refractory glaucoma over 1 year. 38 eyes were treated with a mean follow-up of about 18 months. The mean fall in intraocular pressure was 38.6%. Analysis of 3 success criteria. Success varied between 74 to 78 at the mean follow-up time, and complications occurred, mainly inflammation and conjunctival congestion, in 8.4%, including phthisis bulbi in 0.6 and persistent hypotony in 1.5. There was no mean visual loss. And therapeutic ultrasound appears to be safe and effective for treatment of refractory glaucoma. This is just to show that the energy concentration is over a smaller area than TSCPC. And so these are the literature searches that I did. And they also said that both of them are safe and effective methods for the treatment of refractory glaucomas. Nevertheless, the pain is less severe with UCP. And this study also says almost the same thing, though they say the reduction in intraocular pressure is better with the cyclodiode treatment, but then the complications are less with the ultrasound treatment. So based on cumulative evidence on safety and efficacy, the range of indications for cyclodiode procedures may be expanded so that the patients with less severe disease and better overall prognosis are treated with such modalities. The role of cyclodestruction in glaucoma management will most likely continue to evolve because of the introduction of novel technologies such as the endoscopic diode cytophotocoagulation, circular high frequency cytophotocoagulation, and micropulse transscleral diode photocoagulation. So early evidence with these recently introduced technologies suggests that they have a clinically acceptable efficacy and favorable safety profile. So confirmation of this requires more studies, larger studies, so that we can actually adopt them in clinical practice. Thank you for your attention. So with that, I stop my screen sharing and we'll move on to the discussion. So I think the first question we have here for Shushmita is that UBM can be done in a sitting position without lying down.
I always do it lying down. I found it much easier and much more comfortable actually for the patient, because you need a water bath, and I think I haven't ever tried it, but I would think that the fluid would keep falling out or something, because it's difficult with the cup and fluid. You would
So what I gather is that there is a separate UBM which can be done.
Well, you do have a clear scan technique as well. I found that the images are not as good as the direct probe, and frankly, it's a little less cost effective because each sleeve costs 2,500 rupees.
Okay.
So using a scleral shell is that much. You can reuse it, but then even the images are better. So I haven't found any advantage of doing that. We do it like that.
And if you reuse that, is it like etiolable, or is it like?
No, we just wash it with soap and water and reuse it, because it's an external thing. Yeah.
Okay, so that is actually a problem also in COVID times. Unless, of course, you wash it.
Maybe, yes, that is true. But then even this is contact. When your scleral cup is coming in contact, your tonometers are coming in contact. So glaucoma has a problem with that.
Yeah, true. And the other question which Dr. Sunita would like you to answer is that how far are we from the ice stents which are supposed to come, and how long is the learning surgical gonioscopy curve, or how difficult is it, how steep is it?
Yeah, so iStent I think already has come. They have got DCGI approval, and I think training has started in 4 centers, wet lab training for the iStent. So I think it will come very soon now, maybe within 2 to 3 months, as far as I know. And as far as intra-operative gonioscopy is concerned, I think I would suggest first, I think, to do extensive gonioscopy in the clinics, because it's very important to identify the angles, all the structures very clearly in the clinics. And once you are thorough with it, I'm not talking about the glaucoma specialists because they already know gonioscopy, but I think all these mixed procedures are going to be done by cataract surgeons also, because they do high volume of cataract, and it is like, injecting mixed device into the angle. So I think they are going to be used extensively by the cataract surgeons. So I think first advice is to learn the gonioscopy in the clinic, and then for intraoperative gonioscopy, I think before doing cataract surgery, it is better that you do intraoperative gonioscopy in the cataract patient. Just tilt the microscope 30 degrees towards you, and head of the patient 30 degrees away from you, and use Swan Jacob type of lens with the handle to see the angle. So I don't think it is very, very difficult. I think with practice, it can be learned. Maybe I think it will take 10, 15 cases to learn if you already know the gonioscopy very well.
And any idea about the price in the Indian scenario?
Price, I am really not aware, but I think they are going to make it less, looking at the, the Indian scenario. But I am really not sure right now.
I think it would be still expensive, even after reducing price.
Because we had the express shunt, which costed us something like about 32,000 rupees. And but then, it went out of the market for no reason, actually, maybe because it was not cost effective, their production. But otherwise, I do have patients who still come back with the express shunt done almost, say, 8 years, 9 years back. And they're quite...
I think you have a lot of experience on it
On the express shunt, yeah. And people come back with quite adequate control of intraocular pressure even after 7 years, 8 years with the express shunt. Yeah.
Express, the only problem is once it fails, then you cannot do needling.
Yes,
Then
you cannot do needling.
Mm.
Yeah, but when Sunita was showing the video of,
Eye stent?
Yeah, a stent, just, releasing it, it's very much like the express shunt. It's preloaded and you just got to press that piston to release it. Yeah.
It is ab interno, and that was ab
Yes, but the fact remains, yes, but that you've got to do a good gonioscopy and release it right at the right place, basically.
Yes.
Yeah.
I think the problem with the Express was that it wasn't giving that much of an advantage over a trap to justify its cost. I mean,
Yes,
at least for centers like ours, I had to be convinced that I would, give anything more with 32,000 or 35,000. That's what I told them. You have to.
Yes.
That was
It wasn't cost effective, yes.
Yeah, but as Dr. Chandrima said, I have quite a few patients, 7, 8 years, very good lab.
Yes.
But the only problem when it fails, so cost effective, no, definitely cost, no.
Yes.
Trab is gold standard.
Yes, absolutely.
I feel Trab is still the gold standard.
It is.
Nicely done, Trab. I think pressure control and everything is excellent.
Absolutely. And do we have time? A little bit more, isn't it?
10 minutes.
So, can we have your opinion on the newest drug, Netarsudil? Dr. Tuli, where are you? And everybody else, I have very mixed experiences in the sense that IOP lowering is effective, but terrible hyperemia. I think out of 10 people, if I give, I've got to withdraw it in 7 people because of the hyperemia. So your experience.
Well, that's what I wrote, ma'am, in one line, but I think I'll request the other panelists to add to what their experience is. We've had limited experience, actually, if it was introduced 2 years back, but actually because of lockdown, it's hardly been 6 to 7 months of.
Yeah, Dr. Chandrima, I think you are absolutely right. I am using it as a third line, not even second line. So hyperemia is a problem, and we need to withdraw most of the patients, like 50% of the patients. So I do experience hyperemia. In fact, I experience it more than Ripasudil. Ripasudil has slightly less hyperemia as compared to Netarsudil.
We used Ripasudil in 7 patients, more Netarsudil. So recently Shefali was analyzing, hyperemia is more than 50%. The IOP reduction in what small series we had, the Netarsudil was 0.3, 0.4 millimeter more. And 4 patients out of nearly 39, 4 patients had corneal edema. And 2 with Ripasudil and 2 with Netarsudil. And then I look back the literature, and there are case series of 6 patients of corneal edema after ROCK inhibitors. And though lots of literature that it improves the corneal function, they also found that all the patients who had corneal dysfunction, some form of either endothelial dysfunction or corneal pathology, they are at high risk of developing corneal edema. And all the 4 patients which we had, all had corneal pathology. One had graft done. One patient's corneal endothelial cell count was around 2,000. Another 2 patients also had corneal pathology. So that is something we have to remember.
Right. Shushmita, your experience
been, ma'am? How has your experience been? Because I think you've used a lot in BBI.
Netarsudil I have used, yes, but as I told you that I'm not very happy with it. And like Sunita said, I agree totally that I use it as a third line or maybe a fourth line also. Definitely not as the first line or second.
I'm talking about the endothelium, not the hyperemia.
With the?
With the endothelium part, I was not talking about the hyperemia.
The endothelium part, well, I very strictly don't use it in any kind of a compromised cornea.
No, because there was a recent webinar where one of the panelists had suggested that it clears up a mildly edematous cornea. So that is a comment I was asking specifically.
Absolutely, there are lots of publication, but and the case series was published last year sometime in September in BJO or October. I don't remember exactly. They had 6 patients. And they also found that everybody had corneal pathology. And we had 4 patients all had corneal pathology. So maybe not in every patient, maybe if there's a mild dysfunction, maybe it helps. Maybe it doesn't help in all patients. But corneal edema, and there I was talking to other people, I was talking to Ronnie, some other people in South, and they all say that they have seen corneal edema.
So it can work both ways. Let's put it that way.
We don't know. We have to figure it out. What?
Yeah, so that's what I mentioned in my presentation, that we need more experience.
Yes, correct.
Either
your inputs.
Yeah, similar. I mean, there's hyperemia, but thankfully the pressure lowering, especially in the COVID time when our OTs were shut, in that sense, if you just tell the patients to hang in there, because remember the hyperemia is not so much ocular surface problem as much as it is vasodilatation. So it's not irritating to the patient, but it's cosmetically a little worrying. But the intraocular pressure did go down, maybe for the same reason as to why the intraocular pressure goes down, the vessels also dilate. So in that sense, it was.
So ma'am, will it be a fair statement or a consensus to make for the large audience which is watching us that it's not still a first line drug to start in open angle glaucoma?
No, that's not a first line at all. Prostaglandin analogs is the first line. There's no doubt about it.
Yeah, because in today's clinic, in the morning clinic, I saw at least 3 patients referred where their first choice was one of these, and then they started with brimonidine or whatever they wanted to over the last 2 months. So I think that is a message that it's okay to go. I mean, don't be floored by something new. It's okay to go with what is established, and then yes, definitely you can try it pre-surgery or pre-trabeculectomy if the pressure is not getting controlled. So I think that's a message that.
Dr. George, can we have your opinion with the huge number of patients you see at Aravind Madurai?
Still very limited experience, and I don't have nothing more to add from what has been discussed already. We reserve it as probably patient is already on a fixed dose combination, either a timolol or dozolamide or even a brimonidine brinzolamide and a prostaglandin at night, and you need to hang on there for some more time before you opt for surgery. That is where we start netrasudil or ripasudil. Conjunctival hyperemia is a severe problem for us. But probably we have not used it in compromised corneas. We are yet to see corneal edema. But as Dr. Devan said, I would strongly say that it is definitely not a first-line management. In our hands, in fact, it's the 4th medicine we start.
Absolutely. So is there anything else? I think we have another 5 minutes to go if you want to ask anything or discuss anything.
Can I ask a question to George, please?
Yes.
George, I think people are not clear, even for us in glaucoma circles in North India. What would be your top 3 indications for doing a primary tube? You can include the secondary glaucomas there.
Top 3 indications, probably aphakic patient, especially both in adult and pediatric. Second indication would be ocular phacomatoses like a Serge Weber. And third would be probably post-vitreoretinal surgery. You have a buccal or even silicone oil, post-silicone oil removal. So probably these are the 3 top indications I can think of right away.
Yeah, I think these are fair. And for me, I think if I were to add, we don't see as much of phacomatoses here. But what I would do is where a retina person has done extensive ablation of the retina and still there is enough rubeosis, especially in the superior quadrant, I would consider that in a NVG.
Yes, so, Devan, definitely. Yes, all those indications are there. Like neovascular glaucoma, definitely you could consider a primary tube. Many of these developmental glaucomas also, like Axenfield recurve, aniridia.
In neovascular glaucoma, if the patient is phakic, still you will consider, because results of TRAB are also good after PRP and Avastin.
So
in phakic patients.
Sunita, my disclaimer was that in the rares, 1 out of 10 patients where the rubeosis is still not regressed enough, and it's enough still in the superior quadrant of the iris, where you would like to do a TRAB, and that angiogenesis is enough to cause a scarring or a failure of the trap. So that would be the indication. Yeah, phakic patients actually they don't bother because we put in that we would just limit to 1.5 millimeter inside. So a short tube and with the iris is enough there. I think that is there, but it should be in the middle of the AC.
Yeah, because of neovascularization, generally these patients have extensive PAS also. So if it's a CRV with extensive neovascularization, so angle is also closed. So I really like that's always a question whether to do a primary tube or just do a trap first, and then maybe later when cataract also develop, you can do a combined phaco tube or something like that.
And ma'am, one more question for Rajul if he's there. Rajul, how much have you shifted during the lockdown specifically, especially the second wave? How much have you shifted to teleglaucoma? Because we had a very impressive talk by you just 2 weeks back or 10 days back. No. So how much have you actually shifted during the second wave?
No, not very frankly. In a sense, counseling patient on the phone, yes.
No, but, not that. I mean, giving
for a
first time opinion, first time, not a follow-up patient.
No. I consulted new patients online, but I refused to start medication. So I advised them to go to nearby. I gave them the reference of the doctors where I felt that they will do a good glaucoma workup, other than glaucoma specialists if they don't have. But I didn't treated any patient. I don't think
so limited role. I think the summary is it's limited role.
It's not possible. Yeah. In a sense that I think medical legally will be more trouble.
I think, ma'am, the buzzer is off.
Thank you. Yes, thank you very much. Thank you, each one of you, for your brilliant talks and being a part of this IC. Thank you very much. Thank you. Stay safe.
I would also like to take this.
Bye-bye.
I would like to take this opportunity to thank each and every one of you for sharing your screen time, your virtual time, and for all the lovely presentations. Thank you, ladies and gentlemen. And I would also like to thank Dr. Paul for conducting the whole session. Dr. Chandrima, Paul, thanks a lot.
Thank you very much.
Thank you. Bye.